Hello everybody, my name is Christina Tepedino. I'm a PGY1 pharmacy resident here at Lowell General Hospital, and today I'll be talking about how the pharmacy department implemented a multidisciplinary process to assess and address medication compliance for our COPD patient population. I have nothing to disclose. The objectives of the presentation today are to review causes and pathophysiology of COPD, also known as chronic obstructive pulmonary disease. We'll also review the pharmacologic standard of care for both chronic management of COPD and for acute exacerbation of COPD. And lastly, I'll describe the process by which Lowell General Hospital attempted to address compliance issues for COPD patients while they were hospitalized. I'd like to begin with a few facts about COPD. Firstly, COPD affects about 10% of people worldwide and at least 16 million patients in the United States. It's the third leading cause of death and hospital readmissions here in the United States, and we currently spend about $40 billion annually on COPD-related costs, and that's projected to increase up to $49 billion annually by the end of 2020. And lastly, about 20% of patients who are hospitalized for an acute exacerbation of COPD are readmitted to the hospital within 30 days. Now that we've gone over a few facts about COPD, I'd like to briefly discuss the pathophysiology of the disease state. COPD is characterized by persistent respiratory symptoms and airflow limitation from airway or alveolar abnormalities. On the right-hand side of the slide, there's a picture comparing a healthy bronchial and alveoli to a COPD bronchial and alveoli. In the bottom picture of the COPD lung, you can see thick, narrow bronchioles with excess mucus. This inflammation and narrowing of the peripheral airways leads to reduced FEV1. FEV1 is a measure of lung function, and it's the volume of air that can be forced out in 1 second after taking a deep breath. The clusters in the picture represent the lung parenchyma, and this is the portion of the lung that's involved in gas transfer, also known as the alveoli. What happens is the parenchyma are destroyed due to emphysema, which also contributes to airflow limitation and leads to decreased gas transfer due to reduced surface area. There are many risk factors associated with or thought to be associated with the development of COPD, but today we'll be discussing just the major risk factors for COPD, and the biggest risk factor is tobacco smoke. Patients who smoke cigarettes have a higher prevalence of respiratory symptoms and lung function abnormalities at baseline. Additionally, cigarette smokers also have a greater COPD mortality rate than non-smokers. Additionally, other types of tobacco and marijuana are also considered risk factors for COPD, as well as environmental exposure to tobacco smoke. A next major risk factor is indoor air pollution, typically from burning wood and other biomass fuels that are used for cooking and heating in poorly vented homes. This particularly affects women in developing countries. And then lastly, a major risk factor is occupational exposures, and that includes both organic and inorganic dusts, chemical agents, and fumes that one might be exposed to in their occupation. A diagnosis of COPD should be considered in any patient presenting with major risk factors and with dyspnea, chronic cough, sputum production, history of recurrent lower respiratory tract infections, or history of exposure to any risk factors for COPD, not just the major ones. Some characteristics of COPD that help differentiate it from other diseases like asthma is that COPD typically is onset in midlife. The symptoms are slowly progressive, and a history of tobacco smoking especially or exposure to other types of smoke is going to be characteristic of this disease. When diagnosing COPD, a spirometry test is required to make the diagnosis. A patient with COPD must have a post-bronchodilator FEV1 over FVC of less than 0.7. This number represents the percent of the lung size that can be exhaled in 1 second. Because of the prevalence of this disease, a team has come together to provide a non-biased review of the current evidence for assessing, diagnosing, and treating patients with COPD. This is called the Global Initiative for Chronic Obstructive Lung Disease, also known as GOLD. Their goals are to standardize definitions of COPD and other upper respiratory and lower respiratory disease states. It's all evidence-based and implementation-oriented, and their goal is to increase awareness for clinicians to help treat this particular patient population. Once a patient has been diagnosed with COPD, we can classify the severity of disease with pulmonary function tests and also an assessment of exacerbation and symptom risks. Firstly, we have here the GOLD grades, which were developed by the GOLD guidelines, and they classify the severity of airflow limitation based on a post-bronchodilator FEV1. As you can see, a GOLD grade 1 is associated with mild severity of disease, as the patient's FEV1 is at least 80% of what was predicted. As you move on to GOLD grades 2 through 4, you see the percent predicted FEV1 decline and the severity increase. In addition to pulmonary function tests when determining severity of illness, we can also assess a patient's symptoms and exacerbation risk. This table here is the MMRC breathlessness scale, and it's a patient-guided assessment of how they feel. So a grade of 0 would be defined as only getting breathless with strenuous exercise, while a grade of 4 would mean a patient would be too breathless to leave the house, or they get breathless when doing something simple like getting dressed. Any patient who scores themselves as a 2 or more indicates significant dyspnea, and we would classify them differently when we do our symptom risk assessment. Another COPD assessment test, called the CAT, is a series of questions where a patient can rate their score from 0 to 5, with 0 being the least symptomatic and 5 being the most symptomatic. For example, the first question on this test is I never cough or I cough all the time, and the patient would rate themselves somewhere between there. At the very end of all the questions, they add up their total score, and a patient who scores a 10 or higher is indicative of more significant symptoms. As I just mentioned, the MMRC and the CAT score help clinicians decide severity of disease based on symptoms. A patient who scores an MMRC of 0 to 1 and a CAT score of less than 10 would be considered more mild in terms of symptoms, while a patient with an MMRC of at least 2 or a CAT score of at least 10 will be considered more severe. An additional tool clinicians use to assess severity of disease are to look at the exacerbation history. A patient with more mild disease would have either 0 or 1 exacerbation that did not require hospitalization, while a patient with more severe disease would have at least 2 exacerbations in general or 1 or more exacerbations that required hospital admission. And this table is used to guide therapy when trying to manage our COPD patients. So I'll have you keep that little chart in mind as we begin to discuss the management of stable COPD. The goals for pharmacologic therapy for our stable COPD patients are to reduce symptoms, reduce frequency and severity of exacerbations, and improve a patient's exercise tolerance and health status. Currently, there are no conclusive clinical trial evidence to suggest that any existing COPD medications modify our long-term decline in lung function, so the real staple of pharmacologic therapy for COPD is symptom and exacerbation management. And finally, our inhaled bronchodilators are central to symptom management and are commonly our first line of treatment and sometimes the only thing that we give on a regular basis to our patients to help reduce symptoms. The mainstay of COPD therapy is to promote bronchodilation. This can be achieved by targeting either the beta receptors, which are seen on the left-hand side of the picture in blue, or by targeting the M3 muscarinic receptors, which are seen on the right-hand side of the picture in red. Our beta-2 receptors are targeted by beta-2 agonists, which relax airway smooth muscle by stimulating the beta-2 adrenergic receptors. This results in increased CAMP and produces a functional antagonism to bronchoconstriction. Beta-2 agonists are available in both short-acting and long-acting forms, and our long-acting form, as you can see on the picture here, is called a LABA. On the right-hand side, we have our muscarinic antagonists, both short-acting and long-acting. Our long-acting is also known as a LAMA. Our long-acting muscarinic antagonists block the bronchoconstrictor effects of acetylcholine on the M3 muscarinic receptors that are expressed in the airway smooth muscles, which promotes bronchodilation. Going back to our symptom and exacerbation risk assessment, we can see that our Group A patients, who would be considered our most mildly ill patients, only require a bronchodilator based on the GOLD guidelines. So there is no preference of bronchodilator. It can be a beta agonist or a muscarinic antagonist. In a patient with few exacerbations but more symptoms, we would recommend, based on the GOLD guidelines, either a long-acting muscarinic antagonist or a long-acting beta agonist. In Group C, we have our patients who are less symptomatic but have experienced more exacerbations. Those patients, the preferred therapy of choice is a long-acting muscarinic antagonist because in clinical trials, the long-acting muscarinic antagonists have shown better outcomes than the long-acting beta agonists. And lastly, in our Group D patients who are both symptomatic and have frequent exacerbations, it's recommended to have them on a long-acting muscarinic antagonist or a combination of a long-acting muscarinic antagonist and beta agonist, or in certain patient populations, an inhaled corticosteroid and a long-acting beta agonist. Our long-acting beta agonist and inhaled corticosteroid combinations are more frequently seen in patients with asthma or a high eosinophil count. However, inhaled corticosteroids have been associated with an increased risk of pneumonia, so it is not typically first line for COPD. When prescribing inhalers for the management of chronic COPD, there are many options listed. There are 5 different long-acting muscarinic antagonists available, with revefenacin being the only nebulized version. There are 5 long-acting beta agonists, 2 of which that are available as nebulizers, and that's the Perforomist and the Brovana. You can also have a combination of any of these generics as a LAMA and a LABA together, and those are available under the brand names Stiolto, Bevespi, Anoro, Udobron, and Duaklir. You can also prescribe patients with COPD an inhaled corticosteroid and a long-acting beta agonist combination. The inhalers that are approved for that indication are Advair Wixela, Symbicort, and Breo. Lastly, there is one inhaler available that is a combination of all 3 drugs for COPD, and that's called Trelegy. While the goal of COPD treatment is to manage symptoms and prevent exacerbations, that cannot always be done. So next we'll talk about how to manage an acute COPD exacerbation based on the GOLD guideline recommendations. Firstly, what is an acute exacerbation of COPD? That's defined as an acute worsening of respiratory symptoms that results in the need for additional therapy. This can be associated with increased airway inflammation, mucus production, or marked gas trapping, which all contribute to increased dyspnea. Additional symptoms a patient could experience include increased sputum purulence and volume, as well as increased cough and wheeze. The reason COPD exacerbations are so important in the management of COPD is because they have a negative impact on our patient's health status, the rate of hospitalization and readmission, as well as disease progression. Our treatment goal for an acute exacerbation is to minimize those negative impacts of the current exacerbation, as well as to prevent the development of subsequent exacerbations. When it comes to assessing the severity of a COPD exacerbation, we have mild, moderate, and severe. All severities don't require hospitalization, but the more moderate and severe exacerbations that do require hospitalization can be further classified into 3 categories. Those categories are no respiratory failure, which is in the top box, and that's associated with a respiratory rate of 20 to 30 breaths per minute, no use of their accessory respiratory muscles, no change in mentation, hypoxemia that improves with supplemental oxygen, and no increase in carbon dioxide. Then we have an acute respiratory failure that is considered non-life-threatening. The difference here is that the respiratory rate is greater than 30 breaths per minute, and the patient is using their accessory respiratory muscles, and the patient is experiencing hypercarbia, whether that be increased from baseline or elevated between 50 to 60 millimeters of mercury. Our last classification for severity in the hospitalized COPD patient is acute respiratory failure that is life-threatening. The difference here between non-life-threatening is that the patient is experiencing a change in mental status, their hypoxemia is not improved with supplemental oxygen, or they're requiring an FiO2 greater than 40%, and their hypercarbia is either increased from baseline or it's elevated greater than 60 millimeters of mercury, which is the difference between non-life-threatening. And lastly, these patients could be acidotic with a pH of less than 7.25. When it comes to assessing severity of the exacerbation in a hospitalized patient, it isn't going to really change the pharmacologic management, but it could change how we supplement their oxygen, whether that be non-invasive or invasive ventilation. For pharmacological treatment, there are three options: bronchodilators, systemic corticosteroids, and antibiotics. Firstly, we'll discuss bronchodilators. Studies have shown that a short-acting beta agonist, with or without a short-acting muscarinic antagonist, is the initial bronchodilator of choice for an acute COPD exacerbation. There has been no significant difference found in lung function between an intermittent metered dose inhaler or a nebulizer, so one is not better than the other. Additionally, there haven't been any clinical studies that evaluate the use of a long-acting bronchodilator with or without an inhaled corticosteroid during exacerbation, so it's currently recommended by the GOLD guidelines to continue use during exacerbation if the patient's already on it, or to start it as soon as possible prior to hospital discharge. And that typically varies from hospital to hospital and the exacerbation protocol from respiratory therapy. Next, in our pharmacologic treatment, we have glucocorticoids. And data has shown that systemic glucocorticoids for COPD exacerbation can help shorten recovery time, improve lung function, improve oxygenation, and reduce the risk of early relapse and treatment failure, as well as reduce the length of hospitalization. The current COPD GOLD 2020 guidelines recommend for systemic corticosteroids for acute COPD exacerbation prednisone 40 milligrams by mouth daily for 5 days. This is because longer courses have been associated with an increased risk of pneumonia and mortality, and by mouth is recommended and considered to be equally as effective as intravenous corticosteroids. It is important to note that the COPD GOLD 2019 guidelines also included IV methylprednisolone in their recommendation, and they recommended between 40 to 60 milligrams IV daily for 5 to 14 days in select patient populations, and there were doses studied up to 60 milligrams Q6 hours in critically ill patients. However, outcome data from those studies is very limited. Our last line of defense for acute COPD exacerbations are antibiotics. A systemic review of placebo-controlled studies in COPD exacerbation showed that antibiotics led to a 77% reduction in short-term mortality, a 53% reduction in treatment failure, and a 44% reduction in sputum purulence. The evidence further shows that antibiotic use in COPD exacerbation for 5 to 7 days is supported when a patient meets a certain set of criteria. Those criteria can be that the patient is experiencing all three cardinal symptoms, and those symptoms would be increased dyspnea, increased sputum volume, and sputum purulence. A patient can have 2 out of 3 of those cardinal symptoms if one of them is sputum purulence. And another indication for antibiotics in a COPD exacerbation is if mechanical ventilation is required. Initial therapy for a COPD exacerbation empirically is typically an aminopenicillin with clavulanate, a macrolide, or a tetracycline. Sputum cultures are not recommended in all patient populations. However, they are recommended for patients who have had frequent exacerbations, are experiencing severe airflow limitation, or patients who are intubated on mechanical ventilation. And it is important to note that by-mouth antibiotics are preferred and recommended by the guidelines, unless a patient can't take PO, in which case IV would be recommended. Now that we've discussed both management of chronic COPD as well as an acute exacerbation, I'd like to discuss the initiative from the pharmacy department to address COPD patient compliance issues. Just to give you some background of the study, through research, we found that acute COPD exacerbations and hospital readmission rates have been linked to medication noncompliance and non-adherence. We also know that it's well established that having a pharmacist involved in the MedRec process is beneficial, but pharmacists are also uniquely qualified to do an assessment of medication compliance while they're doing a medication reconciliation. At Lowell General Hospital, most medication reconciliation occurs in the emergency department right when a patient's admitted. So at that time, it's really not ideal to address a compliance issue, and that can be challenging at the beginning of an admission. Because of these things, the goal of our project was to identify the best method by which we could address medication compliance in hospitalized COPD patients, and we wanted to do this using a multidisciplinary approach. Our aim was to identify noncompliant COPD patients, assess and address reasons for noncompliance, and reduce the risk of readmission. This initiative required multiple phases of implementation. The first phase involved collecting baseline data, which was done from October 1st through December 31st, 2019, and involved tracking the number of days with a pharmacist in the emergency department, how many MedRecs got done, and how many of those MedRecs were for COPD patients. At this time, we also developed a standardized emergency department medication reconciliation form to standardize our process in the ED. Additionally, a COPD inpatient report was generated, and this report updated in real time and included inpatients with COPD as their primary ICD-10 code diagnosis or problem. Lastly, during Phase 1, we developed the compliance algorithm in combination with pharmacy, continuity of care, and respiratory therapies input. This compliance algorithm is an 8-part yes or no questionnaire that evaluates a potential barrier to noncompliance and then provides the pharmacist with a situation-specific plan to implement based on what they identified. Here is a picture of the algorithm broken up into 4 parts. The first section asks 2 questions, and all questions are prefaced with, "In the past 90 days, have you?" So the first section addresses questions that could be addressed by continuity of care. And those questions are, have you been unable to afford your COPD medication copays, and have you had difficulty getting to the pharmacy to pick up medications? If the patient answered yes to either of these questions, the pharmacist in the emergency department would consult continuity of care to help the patient address this issue before discharge. And that was done via a Tiger Connect message to the ED case manager for COC. The next 2 sections represent respiratory therapy's involvement in our algorithm. The 2 questions that would result in an inhaler teach by respiratory therapy are, have you had any changes or new medications for COPD prescribed, or have you had a change in your ability to self-administer medications? If the patient answered yes to either of these questions, respiratory therapy was consulted via power chart with the inhaler teach RT consult. A third question that was specific to respiratory therapy was, have you taken your maintenance inhaler less often than prescribed? If they answered yes to this question or didn't quite understand the severity of their disease, they were referred to respiratory therapy via power chart for a COPD teach-back. This is where respiratory therapy would come in and do some education with the patient about their disease state and the importance of adherence and taking care of themselves. And that is something that respiratory therapy already did, so it fit perfectly into our algorithm. The last section represents the pharmacist's involvement in our algorithm. If the patient answered yes to these 3 questions, first one being, have you not taken your COPD medications because of adverse effects? Have you forgotten any doses of your COPD medications? And have you felt overwhelmed by the number of meds you take or felt like you were not taking the right medication at the right time? If the patient answered yes to any of these questions, the pharmacist in the emergency department would not address these issues currently, but they would consult the inpatient clinical pharmacist, and that was done via power chart for the pharmacy COPD consult. This way, any issue that needed to be addressed would not be done right in the ED as a patient was getting admitted, but rather it could be done throughout the hospital course prior to discharge. After the algorithm was developed and baseline data was collected, Phase 2 of the implementation involved education. There was both pharmacist education on how to use the medication reconciliation form, run the COPD inpatient report, and implement the algorithm. This was done via a 1-hour continuing education event provided to pharmacists about COPD. The algorithm was introduced to those in attendance, and further in-person training and handouts were provided specifically to those pharmacists who rotated through the ED and other non-intensive care units. Education was also required for our teammates in respiratory therapy and continuity of care regarding their involvement in the algorithm and the project's goals. The dissemination of information to both respiratory therapy and COC was done via email to their managers, who then educated their respective departments on the new pharmacy-driven consult process. After all parties involved were educated on the implementation and the process of our plan, we began Phase 3, which was the implementation. The COPD compliance algorithm and its process were implemented on January 6, 2020. At this point, the ED pharmacist became responsible for running the COPD list periodically throughout his or her shift, targeting specific COPD patients for medication reconciliation, and consulting the appropriate team based on the algorithm's results. And this service was offered whenever a pharmacist was assigned to the ED and excluded weekends and holidays. Throughout this process, from date of implementation, we had a multidisciplinary group of key stakeholders from pharmacy, respiratory therapy, and COC who met monthly to review patients, review processes, talk about areas for improvement, and also we adjusted the algorithm as needed to develop additional interventions that we came across. Additionally, our data collection period was designed to run through March 31st, 2020. However, due to the COVID-19 pandemic, we had to suspend unit-based pharmacy services, and data collection had to be terminated early on March 15th, 2020. Data collection for the study period involved our inclusion criteria, which was any patient who was admitted to Lowell General Hospital through the main campus ED and also had one or more of the following ICD-10 codes as their primary diagnosis: COPD unspecified, COPD with acute exacerbation, or COPD with acute lower respiratory infection. Patients were excluded from our data collection if they were non-English speaking or unable to participate in medication reconciliation, and they didn't have a family member or caregiver who could participate on their behalf. Data collected included the patient information, when they were admitted, the date their meds were reconciled by the pharmacist, who that pharmacist was, and whether or not they had a COPD diagnosis. Additionally, we assessed whether compliance was assessed by the pharmacist, if they identified an issue, and what type of intervention via the algorithm they made. And lastly, we tracked whether any consult initiated by the ED pharmacist, whether it was completed by the appropriate team member, and what that team member did to address the issue. The primary outcome we were looking at was the number of non-compliant COPD patients who were referred to the appropriate resource. Secondary outcomes included the number of COPD medrecs performed, the number of times each team was initiated in the algorithm, and the number of referrals that were made by the ED pharmacist acted upon by other members of the team. Here we have our baseline versus study period comparison results. From October to December 2019, there were a total of 34 out of 92 days where a pharmacist was deployed to the emergency department. During those 34 days, pharmacists completed 137 medication reconciliations, and 32 of those were for patients with a diagnosis of COPD. During the baseline period, compliance was not assessed because this was not something we were routinely doing before the protocol was implemented. During the study period, January to March 2020, there were 33 out of 70 days with an ED pharmacist presence. In those 33 days, the ED pharmacist completed 189 medrecs, 53 of them being for patients diagnosed with COPD. We assessed compliance in 49 out of the 53 COPD patients, and 10 compliance issues were identified. Of those 10 compliance issues identified, 9 of them were referred to a team through the algorithm, and of the 9 referrals, 8 of them were consults that got completed. This table represents results broken down month by month for the study period. In January 2020, there were 2 patients for whom the ED pharmacist identified a compliance issue. 1 patient was appropriately referred, while 1 of them was a missed opportunity. In February 2020, there were 5 patients identified with a compliance issue, and all 5 of them were appropriately referred. In March 2020, the ED pharmacist identified 3 patients with compliance issues, all of whom were referred to the appropriate resource upon admission. Of those consults, 100% were completed in January and February, and 2 out of 3, or 66%, were completed in March. Regarding our secondary outcomes, in the 3 months since the COPD compliance algorithm was introduced, it was utilized to consult a different member of the multidisciplinary team for 10 unique patients. These 10 patients required 13 consults based on their answers to the algorithm's questions. Respiratory therapy was consulted 5 times for disease state and inhaler education. COC was consulted 3 times for financial and transportation barriers to compliance, and inpatient unit-based pharmacists were consulted on 5 occasions regarding medication noncompliance due to adverse drug events, overwhelming medication regimens, and also forgetfulness. Of the 13 consults ordered, 10 were completed by the assigned team. For the 3 incomplete consults, 2 were for a patient who unfortunately expired on day 2 of the admission, and 1 pharmacy consult was ordered in error on a patient who also had a COC consult for the inability to afford inhalers. For the number of medication reconciliations performed for COPD patients specifically, at baseline it was 32 out of 137, and during the study period it was 53 out of 189. Based on our results, we found that the development of the compliance algorithm empowered the ED pharmacist to identify a barrier to compliance at admission and consult a team who could then address that issue during the patient's hospitalization prior to being discharged. Initiating the COPD compliance algorithm allowed us to assess the compliance of 49 COPD patients during MedRec in our 3-month study period. And of those 49 patients, pharmacists identified 10 patients with a barrier to compliance. 9 out of 10 of those issues were referred to the appropriate resource before discharge, and we did define 1 out of 10 patients as a missed opportunity. This patient was identified during the very first week of the protocol's initiation and led to some confusion as the patient was unable to afford his inhalers. However, he was getting free samples from his PCP. So we discussed this missed opportunity at our January quality assurance meeting and used it as a re-education tool with our pharmacists in the ED so they would know in future encounters to still refer this patient to continuity of care if needed. Additionally, referrals were made to each team, and some patients required consults from more than 1 team at a time, and this demonstrates the benefit of trying to address medication compliance via a multidisciplinary approach. Every patient is different, and compliance issues can often be multifactorial, so it's not always just one issue that's a barrier to compliance. It can often be a multitude of issues, as evidenced in a few of our patients. There were also some limitations of this study that I'll briefly discuss. Firstly, the creation of our COPD inpatient report did not appear to increase the number of patients with COPD who had their meds reconciled by a pharmacist. This finding could have been confounded by selection bias. The ED pharmacist knew that the number of their COPD patients was being tracked during the baseline period, and this could have resulted in subconsciously targeting patients with COPD prior to having a report made available to them. And regarding the COPD report, it was only able to identify patients who had a primary admission diagnosis of COPD. This report was intended to encompass all inpatients with a current diagnosis of COPD, regardless of whether it was a primary, secondary, or unaddressed problem during admission. Thirdly, COVID-19 led to a suspension of unit-based pharmacy services on March 15, 2020, which led to an early termination on our data collection. Because of this, the run-in period was 92 days, while the study period was only 70 days instead of the intended 86. Had the data collection been completed as initially intended, the results could have potentially shown more COPD patients with MedRecs by a pharmacist, as well as more compliance issues identified and addressed during admission. Lastly, our ED pharmacist presence is not well defined at Lowell General Hospital. We only deploy unit-based pharmacists Monday through Friday from 7 a.m. to 3:30 p.m., and we preferentially send our pharmacists to the cardiac and intensive care units. Therefore, our pharmacy presence in the ED is sporadic and it's very heavily reliant on the day's scheduling model. To conclude, while the Quality Improvement Initiative didn't identify many non-compliant patients, it's nevertheless an important process for pharmacists to be involved in. This initiative empowered our pharmacists to consult appropriate resources for a non-compliant patient on their own at the time of identification, and the pharmacists were able to feel confident that the issue would be addressed prior to discharge by the appropriate team. There are a few next steps that could help ensure the Quality Improvement Initiative is successful. Firstly, the generation of a more robust COPD inpatient report that includes all patients with any type of COPD diagnosis in their history would help. This is an issue that's actively being worked on by pharmacy informatics and Cerner providers. Additionally, the algorithm could be expanded beyond the ED pharmacists to all of our unit-based pharmacists inpatient. We do conduct medication reconciliations on the inpatient floors within 24 to 48 hours of admission if they were not reconciled by a pharmacist in the ED. A simple tweak to the algorithm for our inpatient pharmacists would just be replacing the contact for COC from the emergency room case manager to whatever floor the inpatient is on. And lastly, once the protocol has been rolled out hospital-wide, a version of this compliance algorithm could be considered for use for other disease states such as diabetes mellitus and congestive heart failure. So with that, I thank you so much for your time, and if you have any questions, my email is provided on the very first slide. Thank you so much.